Hello everyone and welcome to our module on diabetes mellitus. Diabetes mellitus is a chronic disorder of elevated blood glucose levels. It's caused by either a lack of insulin or a poor response to insulin, and when the cause is a poor response to insulin, we call this insulin resistance. Remember that insulin triggers cells in our body to take up glucose from the plasma, so if there's a lack of insulin or a poor response to insulin, then glucose won't be taken up by cells and it will persist in the plasma, and this leads to elevated blood glucose levels. Diabetes mellitus is bad for a couple of reasons. First of all, it can lead to symptoms of hyperglycemia, and we'll talk about these in a minute. But more importantly, when there's chronic hyperglycemia, this leads to a number of serious long-term complications. This includes vascular disease like stroke and heart attacks, also kidney disease, blindness, and a number of other complications. And it's mostly because of these long-term complications that diabetes is such a serious chronic illness. Diabetes mellitus can be asymptomatic, and it's sometimes considered one of the silent killers along with hypertension and hyperlipidemia. These are disorders where there are no symptoms until serious complications develop. And because diabetes mellitus can be asymptomatic, especially in early stages, this is the basis for screening, which we'll talk about later in this video. When symptoms of diabetes do develop, they're usually related to hyperglycemia. And the classic hyperglycemia symptoms are polyuria and polydipsia. When the blood glucose level gets high, it will spill into the urine and it will draw water into the urine with it. This is called an osmotic diuresis caused by the high glucose levels, and this leads to lots of urinary volume, and therefore the patient will complain of frequent urination or polyuria. And then because patients are urinating frequently and losing free water in the urine, they will become thirsty, wanting to replace those lost fluids. And so patients with diabetes who have hyperglycemia can also complain of being thirsty all the time, in addition to complaining of frequent urination. And then lastly, in another video I talk about diabetic ketoacidosis, which is a life-threatening condition that can develop from hyperglycemia. And this is another way that diabetes sometimes presents when the blood sugar levels get very, very high. The criteria that are used to make the diagnosis of diabetes mellitus depend on whether the patient is symptomatic or asymptomatic. Symptomatic patients have clinical features like polyuria and polydipsia or diabetic ketoacidosis. In this situation, symptoms plus a glucose level greater than or equal to 200 is enough to make the diagnosis of diabetes. In asymptomatic patients, there are a couple of ways you can meet diagnostic criteria for diabetes. The first is to obtain a fasting blood glucose level where the patient has had no food for at least 8 hours. A normal fasting blood glucose level is less than 100. Pre-diabetes is considered a level from 100 to 125, and if the patient has a fasting blood glucose level greater than or equal to 126, this meets the criteria for diabetes. Another way to make the diagnosis in an asymptomatic patient is to measure the hemoglobin A1C level. If it's greater than 6.5%, this is diabetes, and we'll talk about the A1C level in just a minute. And then finally, you can also make the diagnosis in an asymptomatic patient by doing a 2-hour plasma glucose tolerance test. This involves administering a 75-gram oral glucose load, and then 2 hours later you measure the plasma glucose level, and if it's greater than 200, this is a diagnosis of diabetes. Let me mention one important caveat regarding the diagnosis of diabetes mellitus, and that has to do with stress hyperglycemia. Stress hyperglycemia is an elevation of blood glucose levels that occurs in normal individuals who do not have diabetes. When normal patients develop infections or have trauma or surgery or have burns, their levels of cortisol and epinephrine in the blood go up, and these hormones raise the blood glucose level, and this is called stress hyperglycemia, and this does not represent diabetes. So usually we don't make the diagnosis of diabetes in a patient during an acute illness or an acute stressor, and that's because they will almost always have stress hyperglycemia present, and that means their blood glucose level will be up, but not from diabetes. Okay, let's talk about hemoglobin A1C. So a small fraction of normal hemoglobin is glycated, and this means that glucose combines with the alpha and beta chains found in hemoglobin. And we can measure the amount of hemoglobin A1C, which is the amount of glycated alpha chains in hemoglobin, and we can use that for diagnosis and monitoring in patients who have diabetes. The percentage of hemoglobin that is hemoglobin A1C reflects the average glucose over the past 3 months. And that's why this is a very handy measurement, because it's not giving you a snapshot in time of the blood glucose. It's telling you how the blood glucose levels have averaged over the last 3 months. A normal hemoglobin A1C level is less than 5.7%, prediabetes is 5.7 to 6.4, and diabetes is greater than or equal to 6.5%. Measuring the level of A1C can be used for diagnosis of diabetes like we talked about earlier, and it can also be used for monitoring the response to therapy. When you're treating patients for diabetes, either with insulin or with oral drugs, the treatment goals are usually based on the hemoglobin A1C level. The lower the hemoglobin A1C in a patient with diabetes, the better the control of blood sugar is, meaning the less frequently that patient is being exposed to hyperglycemia. In patients who have type 1 diabetes, the goal for treatment of hemoglobin A1C is usually less than 7%. In type 2 diabetes, it's also usually less than 7% for the average adult patient. However, higher goals like less than 8% are sometimes allowed in older patients. The reason this is done is that if you want to achieve a hemoglobin A1C less than 7%, you're going to need to administer higher dosages of insulin and higher dosages of oral diabetic medications, and this can cause hypoglycemia. So in older patients who have limited life expectancy during which they can develop complications of diabetes, you often try to avoid hypoglycemia by raising the target hemoglobin A1C level to less than 8%. I mentioned earlier that you can use glucose tolerance testing to make a diagnosis of diabetes. This involves administering an oral glucose load and then measuring the plasma glucose 1 to 3 hours later. And if the glucose level is high and above standard cutoffs, this indicates diabetes. And the main situation in which glucose tolerance testing is used is in gestational diabetes among women who are pregnant. Some degree of insulin resistance is normal in pregnancy, so measuring a fasting plasma glucose or A1C is not reliable. Instead, what you need to do is study the response to a glucose load to make the diagnosis of diabetes in pregnancy. And I talk about gestational diabetes in detail in videos in the obstetrics section. Okay, now let's talk about the two different forms of diabetes mellitus. And the first form is called type 1 diabetes. Type 1 diabetes is an autoimmune disorder. It's an example of a type 4 hypersensitivity reaction in which there is immune-mediated destruction of beta cells in the pancreas. And the beta cells are the cells that produce insulin, so when they are destroyed by an immune-mediated process, this leads to loss of insulin, and that leads to diabetes. The etiology of type 1 diabetes is multifactorial and incompletely understood. There is a genetic component, but also environmental factors play a role. And the only really major established risk factor for type 1 diabetes is family history. If you have a first-degree relative with type 1 diabetes, your risk is higher compared to people who do not have a first-degree relative. Type 1 diabetes is mostly a childhood disorder. It has a bimodal age distribution. There's one peak at 4 to 6 years of age, and then a second peak at 10 to 14 years of age. And usually it presents with symptomatic hyperglycemia. So children who develop type 1 diabetes will present with polyuria and polydipsia. If you do urinary testing, there will be glucose in the urine. And they can also present with diabetic ketoacidosis, which, as I said earlier, I discuss in detail in another video. Unlike type 2 diabetes, which we'll talk about later, there's no standard screening that's recommended for type 1 diabetes. The diagnosis is usually made when symptoms occur like polyuria and polydipsia and glucose is found in the urine. And the treatment of type 1 diabetes always involves insulin. That's because these patients cannot form insulin in the pancreas, so you have to provide insulin replacement. The other form of diabetes is type 2 diabetes. And type 2 diabetes is a disorder of insulin resistance. There's a reduced response to insulin among cells in the body, and because they don't respond to insulin, they don't take up glucose from the plasma, and this leads to hyperglycemia. Initially, when patients develop type 2 diabetes, the pancreas responds by increasing the amount of insulin production, so patients can be hyperinsulinemic when they are initially diagnosed with type 2 diabetes. Eventually, however, if the disorder goes on, the pancreas can fail, and these patients can have low insulin levels, similar to type 1 diabetes. And type 2 diabetes is the more common form of diabetes. It's common among adults. In fact, it used to be called adult onset diabetes, although this term isn't used much anymore because type 2 diabetes is beginning to become more common among children in addition to adults. The major risk factor for type 2 diabetes is obesity, especially central or abdominal obesity. This carries the greatest risk of development of type 2 diabetes. And when patients have type 2 diabetes, if they lose weight, their glucose levels will get better and their hyperglycemia will improve. Family history is also an important risk factor. There is a strong genetic component, even stronger than among patients with type 1 diabetes. For patients with any first-degree relative who has type 2 diabetes, their risk of developing the condition is 2 to 3 times higher than patients who don't have a first-degree relative with diabetes. And then beyond obesity and family history, sedentary lifestyle is also a risk factor, and so is smoking. Type 2 diabetes usually has a slow, insidious onset and a prolonged asymptomatic phase, so for this reason, screening is recommended. The guidelines on exactly who should be screened and when vary slightly by expert groups. So for example, the American Diabetes Association recommends screening most patients beginning at age 45. However, screening should be done earlier in high-risk groups, for example, patients who are obese or have a family history of type 2 diabetes. And then repeat screening, if an initial screening is negative, is recommended every 3 years. Slightly different screening guidelines come from the U.S. Preventative Services Task Force. They recommend screening patients age 40 to 70 who are overweight or obese, and then repeat screening can be done every 3 years. Once you make a diagnosis of diabetes, how can you tell whether the patient has type 1 or type 2 diabetes? Well, you should know that this is usually done by clinical features at the time of presentation. And this is very high yield for your boards. They're going to want you to know how to determine from the clinical features whether a patient most likely has type 1 or type 2 diabetes. So type 1 diabetes will usually have a childhood onset, and there will be a rapid onset of disease, usually with severe hyperglycemia at presentation. And obesity can occur in type 1 diabetes, but it's less likely. It only occurs in about 20% of patients. Type 2 diabetes, in contrast, will occur around the time of puberty or adulthood, and as I said before, it often has an insidious onset. It can be asymptomatic and detected through screening. It may present with polyuria or polydipsia, but the symptoms won't be severe with very, very high blood sugar levels, and the symptoms won't have come on abruptly like they do in type 1. A family history of type 2 diabetes is very likely in type 2. It's less likely in type 1. And then obesity is very common in type 2 diabetes. About 80% of patients are obese. Now, beyond the clinical presentation, there are islet cell specific pancreatic autoantibodies that you can measure in the plasma. These can help identify cases of type 1, although they're not reliable enough that you can depend on them for a diagnosis of type 1 diabetes. Let's talk about the management of type 2 diabetes. So for all patients at the time of diagnosis, they should be advised to maintain a healthy weight and to exercise. If patients can maintain a healthy weight and get regular exercise, this improves insulin resistance, and this can bring the blood sugar down without the need for medications. Some patients can even try weight loss and exercise prior to medical therapy in select cases. If you have a highly motivated patient who's motivated to exercise and lose weight, and the A1C is elevated but it's close to target, in those situations, patients can try a 3 to 6 month trial of lifestyle modification, and if they're successful, they can be able to control their blood sugar without having to take medication. When medication is indicated, the most common initial therapy is the oral drug metformin, which I talk about in another video, and you may need to add additional oral agents to achieve the target A1C level. And usually after 2 or more agents are not working to get the A1C to target, that's when you consider insulin. Insulin is effective in type 2 diabetes, but we usually try oral medicines first. And one thing to know is that when patients present with type 2 diabetes and their A1C is severely elevated, which usually means over 9.5%, in these cases, usually insulin is used initially. When the A1C is this high, it's unlikely you'll be able to bring it down to the target range with oral drugs. You're almost certainly going to need insulin, so often in those cases, we simply begin by treating the patient with insulin. Another treatment that can be very effective in type 2 diabetes is bariatric surgery, which refers to various forms of weight loss surgery. This is indicated for obese patients who have type 2 diabetes. And in some studies, there's been long-term remission of type 2 diabetes in up to 60% of cases after bariatric surgery. The studies have also shown a reduced risk of diabetes complications. So bariatric surgery is indicated for any patient with diabetes who has a BMI greater than 35, and this is the number you want to know for your board exams. It's also indicated for patients with type 2 diabetes whose BMI is 30 to 34.9 if they have hyperglycemia that is inadequately controlled with medical therapy. And then the last thing I'll mention in this video is a skin finding called acanthosis nigricans. This refers to hyperpigmented or darkened plaques of skin. They classically develop at intertriginous skin sites, which are folds of skin, places like the base of the neck or the axilla. This is a picture of acanthosis nigricans in the axilla of a patient here. And you should know that this finding is associated with insulin resistance. It's often seen among patients who have obesity and diabetes, and it's much more common among type 2 diabetes, and that's because it's associated with insulin resistance. And in type 1 diabetes, you have insulin loss, not insulin resistance. In addition to insulin resistance, you can also see acanthosis nigricans in some patients with malignancy. The most common malignancy to lead to this skin finding is gastric adenocarcinoma. And that concludes our module on diabetes mellitus.